Hello to all of you who are taking part in this Universitas 21 Student Healthcare Challenge event. Gosh, what a big question. How to vaccinate the world. I admire you all for taking part in this, and I took the liberty of thinking a little bit as well, and just realising the complexity and the huge challenge that this is. I mean, we've got everything from the host immune response to infection and vaccination, to the properties of the virus, so the virulence and mutagenesis of the virus, to the science and the new technology around vaccine development and the properties of this vaccine to ensure that it is safe and stable and cheap and able to be accessed by all. To think about environmental variation and differences in force of transmission of this virus, which ties nicely into kind of individual health beliefs, perceptions of risks and behaviours. And gosh, underneath all of that, or above all of that, is geopolitics, societal and political direction and messaging. So I hope in your groups you're able to come up with some really interesting discussion points around how we can tackle this huge problem. So today, U21 have asked me to just talk about my personal journey and what I've been doing. My name's Professor Alex Richter. I am a professor of clinical immunology and also a consultant immunologist here at the University of Birmingham. Now, as the pandemic was having its early forays and infections, I got hit by a car and ended up in hospital with an operation to fix my arm. And I was on sick leave and I was watching at home as, first of all, China went into lockdown and then this extraordinary rise of cases occurring around the world. So, in the last couple of weeks of my sick leave, I was obviously kind of re-engaging with work and working out what we could do. I was really limited in my movement in this arm. And I realised those very basic tasks of, being able to tie personal protective equipment and actually be useful as a doctor on the ward was just not going to happen. And I spoke to my colleagues and, to my husband, who is an acute care physician. And I just said, well, what can I do? And the resounding response was, can you sort testing? It was a very scary moment for healthcare workers right back at the beginning. We had no tests, we had very limited PCR testing, and this was just for patients in hospital. So nobody knew who'd been unwell, who was well. We had no control over testing for this virus. And so what I thought I would try and do is get and develop an antibody assay to at least be able to give something back to our healthcare workers, to give them some reassurance as to whether they had or had not yet had this infection. And so, as someone had termed it to me, whether they had dodged the bullet. Now, the first generation of antibody tests lack sensitivity. These assays were optimized for patients with a known COVID infection who were in ICU and, really sick. Think about it back to March 2020. We didn't really even know about mild and asymptomatic infection and what this would look like. And what we found in our early studies was antibody responses varied enormously in quantity. And the more severe your disease was, the higher your antibody level was. And And so these assays were designed for severe disease, but over 90% of individuals did not have severe disease. So what we needed to do was optimize an assay for most of the population. And so we went back to core science and core diagnostic backgrounds and experience. And instead of undertaking usual research, which is where you try something and that doesn't work, and that leads you on to the next step and the next step and the next step, I remember sitting down and having a almost like a crisis meeting, and it's that kind of, right, what are all the experiments we need to do to get this assay as good as we can make it? And so, it was a form of parallel matrix research. So we tested all the variables in all the combinations in one go. And actually, we were able to go from the science and the conception of this to launching a commercial assay with a Birmingham-based company, The Binding Site, in just 4 months. So tremendous effort and testament to teamwork and approach. So when you've got the tools of your trade, you then need to decide what to do with it. And this brought me back to what my first questions were and, how I got involved. Who has the infection? Who has had the infection? And that then led on to the question of who was at risk and how can you then modify this risk and protect individuals who are most at risk. But actually, with these very simple questions, and our involvement with the pandemic, what I found is that the questions that I was being asked and my team was being asked and the research required to deliver this diversified enormously. Obviously, more recently, it is who responds to vaccines, and more importantly in my world as a clinical immunologist looking after patients with immune deficiency, the more importantly, who doesn't respond to vaccination. How long do vaccine responses last? And to which vaccines? Are they as good as each other? How risk groups respond to infection and the probability of getting chronic COVID infection. I've got patients that have been positive to the virus and unwell for 6 to 7 months now because they don't have the immune system necessary to clear the virus. So how are we going to look after these patients and treat them and look at the introduction of these monoclonal antibodies as therapeutic agents? And of course now booster doses and assessing those and assessing who needs them and what the response and impact will be. So as a clinical scientist, I don't just work in the laboratory. I obviously work with patients and I do clinical studies, and a lot of the questions I ask, and the reason I ask those questions is because I see people, I talk to people, and I work out what those kind of leading or the priority questions that need to be asked are. So to ask the question, which healthcare workers have had the infection to establish which are at risk, I set up the COCO study, which is the Covent Convalescent Study. This was in our local hospital, UHB, and we followed up our staff members. In fact, we're still following them up because we're going to be looking at booster responses potentially this autumn and winter. And what we were able to determine really early in the pandemic, that a significant amount of patients participants were antibody positive. So 17% had asymptomatic transmission. But we were also able to really establish that these asymptomatic seroconversion levels had lower antibody levels than those that were really unwell. And we also established that actually being a healthcare worker was an occupational risk. And so, 25% of our workforce was antibody positive in April 2020, as opposed to maybe only 1% of the population at that time. We found that if you were seropositive, you tended to have those with higher antibodies had a more systemic illness and were more unwell. But we also found that these higher antibody levels were also associated with individuals that were more likely to have been exposed to the virus in that first wave. So age, ethnicity, and BMI and male gender were of a higher risk. I mean, the other thing that we found is where you worked in the hospital was important. So individuals who worked on ITU, where some of our sickest patients were actually relatively protected compared to porters and cleaners and healthcare and those in acute medicine. And the difference between these groups is what level of PPE they had. So in intensive care, individuals were in FFP3 mask, so much higher grade protection than the rest of the hospital. And this was protective. So real lessons learned as to what type of personal protective equipment that we should be using in the hospital. As I said, we followed up our healthcare workers over time. Now, we did this because we know that normal antibodies wane after 6 to 8 minutes, 6 to 8 weeks, but not completely. But they just slowly start to dip down, and we wanted to know the level that these antibodies dip down to over time, and we very much hope that they mostly remain detectable. And we found that about 2/3 of individuals still had antibodies at 6 months, and that these antibodies, this was during the alpha wave, which was the second wave in the autumn of 2020, antibodies gave a 79% reduction in risk of reinfection at 6 months. We found that infections were more likely to occur in those individuals that had lower titers, and these lower titer antibodies on the whole waned fastest and were usually lost by about 3 months. So with this waning antibody response, gosh, we've got new questions occurring. So how long is this immune response going to last for? And do we now need to think about vaccine breakthrough and reinfection, especially now with the Delta variant, which is much more infectious, there's more transmission and causes more severe disease. And we know that our vaccines and original immunity against the Wuhan and the Alpha strain doesn't provide as much protection against Delta. So it's interesting to look at infection and vaccination as well. And what we found is for individuals that had had COVID infection, their response to vaccination was absolutely magnificent. So within 4 days of vaccinating an individual with their first dose, they had produced a really high antibody response. And this compares to, usually 4 to 6 to 8 weeks following first vaccination in an infection naive individual. So this gave evidence that we needed to vaccinate people to really boost their antibody response. Remember, I've said that antibody levels need to be higher to afford more protection and last longer. And so we then, it was important for individuals not to just rely on the fact that they'd had infection. They should still go for vaccination. But what we also know is that a number of individuals that have been vaccinated in some of our at-risk study groups, Octave Duo is part of a consortium study that I'm part of, and COVAD, where I am an investigator of a study looking at patients in immune deficiency in the UK. We know a number of individuals just can't produce an antibody or T-cell response. So can we boost these individuals with a third dose of the vaccine? Or If we can't, what are we going to do to protect them? Can we give them these new monoclonal antibodies as a substitute for their own immune system? So with these higher magnitude vaccine responses, one, it's really challenging for our assays, and we were having to think at the tests that we were doing for the accuracy of these tests, because these assays were all established to look at that lower limits of detection for sensitivity to determine who had and hadn't been exposed to the virus. But now we're having to look at 100-fold higher antibody levels in those that had been vaccinated. So not just our thinking and the questions are changing, but the tools we need to address that. And in this case, just just the concentration of the sampling was important. So what else have we done with our testing capabilities? Well, one question I very much was thinking about is there's so many unexplained questions in COVID. You know, what about these strange symptoms of fatigue and, muscle inflammation? And we looked at patients following hospital admission and following illness in the community. And we were able to find self-antibodies, so antibody patterns targeted against the skin and the muscle and the heart. And we're investigating this in a collaboration at the moment. But maybe this is some of the explanation for long COVID, as these antibodies are present 5 months after the illness, but are also more likely in our sicker patients. We were also able to help our children's hospital very early on in the pandemic. I got a call on a Sunday afternoon in May 2020 saying, we've got this cohort of children with this strange inflammatory condition that's very similar to Kawasaki's disease, but they're all negative to COVID on PCR. And I remember thinking, well, get me some serum. So I went that Sunday afternoon to go and collect samples from the hospital and took it back to the lab. And by the next day, we were able to tell the clinicians and these families that they had really, really high antibody levels against COVID. And so what this was is an hyper-inflammatory response, having had COVID in the past. So they didn't have the virus at the moment. This was a delayed immune response, and that helped in the understanding of what these children had. And obviously a lot more has been done on PIMS-TS, or MIST-T as it's also called. Gosh, so to summarise, the only thing that is certain in all of this is that things will remain uncertain, and we need a real flexibility of thinking and approach to tackle this global challenge in an equitable way. There's been a lot of discussion recently about healthcare fairness and how we're in a global pandemic. So unless we all come out of this, there's a real risk of, the virus mutating in different areas. And because we live in a global world where it's easy to travel, we will never get on top of this virus until we are all working together in this incredibly multidisciplinary team way. Now listen, I don't usually spend a lot of time on thank you slides, but I'm going to just give you 2 slides, which again is unusual for me, just to illustrate that tackling this virus, and my very, very small part of this, has been part of a team approach. And these aren't teams that I would necessarily always be aligning with. And what the pandemic has done has brought individuals from a number of different fields, from academics, from basic scientists to, organizational partners and commercial partners, and from all sorts of different backgrounds and different expertises. And what that enables is that we can apply a question to one of the projects that we're taking part in, and then apply that to another. So it is very rapid dissemination of knowledge and sharing and collaboration. And I think, if you just look at some of the titles in this slide, the word consortium comes up a lot. It's about groups, it's about teamwork. And I would encourage you in all of your fantastic careers going forward that you work like that. It's not just great for science, it's great fun. I wish you luck with your challenge, and so look forward to hearing about some of the answers that you come up with. Thank you for listening. So thank you for, in your groups, coming up with some questions for me. And I thought I would just spend a minute or two going through them. Some of these I've covered in my talk to some extent, but I thought it'd just be nice to address kind of each question from each group in a little bit more detail. So group 1 asked, are the vaccines able to prevent the symptoms of long COVID? Well, we're not sure yet. I mean, what we have understood recently is that, unfortunately, if you're vaccinated, you still have the same viral load as if you weren't vaccinated, and you contract the virus and you carry the virus. So this means that the vaccines aren't producing sterilizing immunity, i.e. completely preventing you from having the infection, just that they seem to be reducing the severity of the infection. So what that means is we're not sure about long COVID, and the confidence that we hoped we'd have that the vaccines would prevent long COVID, we're not quite so sure. Having said that, it is likely that it will be better, but I think it's one of those questions that only time will tell. We know that lots of people, it's very difficult to analyse those that have been asymptomatic that have gone on to get some symptoms, but actually I'm not fully aware that individuals who have been asymptomatic with disease have had a particularly significant long COVID. So question 2, how do we predict future pandemics? Well, the WHO obviously have sight of all of this, and they rely very much on the global healthcare monitoring systems to pick up and identify unusual infections or unusual patterns of infections. And you remember back to those early days of March 2020 or February 2020 and January 2020, when it was like, is this a local infection? At what point is WHO going to call this a pandemic? Now, we have a number of studies that are kind of sleeper studies that are set up and reactivated in case of outbreaks like this. And in the UK, we had a study called ISARIC, which was kind of brushed off the shelf. And that meant that we could start collecting samples really early on in the pandemic to make sure that we had samples to study and analyse. So things like this are going to be important. And I think also we just mustn't forget, and we must continue to have some preparedness. Our technology is improving all the time. Our ability to sequence infections and develop. High throughput testing has improved. And I think, really it is the sequencing and the genetic identification of these infections that is going to keep us alive to any new breakthrough infections. So group 3, would be around the process of getting the vaccine approved in such a short time, and whether the processes were fast-tracked or changed for the normal requirements. I've talked about this on a couple of interviews, and I think what was fundamentally different here, and a really nice analogy for me, is if you want to build a house and you want to do it really, really quickly, there are 2 ways you can do it. You can either cut a whole load of corners and use shoddy material and workmanship and get it up quickly. Or what you do is you throw absolutely everything at it. You fold factor the number of workers that you have on the build, and you get it done in a strategically driven, coordinated way. And I think that's what has happened, and I cannot see that significant corners have been cut with COVID. We have as many, if not more, patients in vaccine studies than in usual vaccine studies. It was so easy to recruit for. We had so many patients unwell at the same time, which is incredibly unusual. Compare that to a pneumococcal or a Ebola or one of these other vaccine studies. So I don't think that the studies and the science was, there were any cutting of corners. But what there was goodwill. And this is something I found in the science world as well, is we were able to just cut through some of the red tape, and people weren't focused on other things, so there was no split agenda, and this was the primary effort. And when the whole world has a primary effort, my goodness, we can do something amazing. Group 4, do you factor in the social and economic benefits and barriers in new developing COVID-19 testing during the development process itself? Yes, I mean, this is really important, because what facilities you have available and the skill set you need and the cost of those reagents is absolutely essential. Thankfully, many of the technologies are, rapidly translatable to, remote settings with relatively limited expertise. But I did a couple of talks on this concept of which is the best test. And if you'd asked me this 2 years ago, I would have said the test that has the highest sensitivity and specificity. But actually my thinking has evolved and developed quite a lot on this, and this is what COVID has driven. And I sat on the on a saliva testing group with in the UK, part of the UK government, to try and look at different viral testing strategies, rather than using just PCR on swabs, thinking about saliva, using kind of LAMP and LAMPOR technologies. And for me now, the best test is the one which is easiest to get the sample. At the time we didn't have enough swabs, for goodness sake, so trying to use alternative, just a simple container to collect saliva. And that's much more palatable to many people than, having unpleasant swabs up the nose and throat. Through to transport. That sample's got to be stable so it can be processed. And then, of course, you want a test that has the least or the simplest processing time. And that has to be in as rapid a turnaround as possible so that it can be actioned. And it must be a really straightforward answer as to, is this yes or no? And you must have very few false positives and a few false negatives. And that, even at the end of this assay, it must be easy to interpret, the result. And not that you need really trained staff to be able to interpret it. We need to be able to have the staff in the laboratories potentially, or if this is a point of care test, to be able to do this. And the testing, of course, must be cheap and simple and be able to be performed, in the Arctic and in the Sahara Desert. So, yes, all of these factors are important. And so, the way I think about what is the best test has changed beyond all recognition. Group 5, is it possible to vaccinate the world and achieve herd immunity given there are so many barriers, including vaccine hesitancy, access and supply? I don't think we can achieve herd immunity, and I'm not even sure, with a rapidly mutating virus, that will ever be possible. But I think we will continue to have little outbreaks, and it is likely that this virus is going to be around for a number of years, and I think we are going to have to continue to vaccinate. We've never achieved herd immunity with influenza, and I suspect COVID is going to be the same. I agree with you on access and supply, and this is a real issue. We are a big world. And, we've done amazingly to get so many people vaccinated in 9 months, but we just don't have enough vaccines. And we're in this moral dilemma now of, do we use boosters in some parts of the world when other parts of the world haven't even given their vulnerable healthcare workers a vaccine? Vaccine hesitancy is a big issue. Fascinating how it's come to the fore. Vaccine hesitancy is not a single concern. It's a really complex movement. We've got individuals who just have a personal concern because vaccines are associated with side effects, and so they are just personally nervous about it for them and their family. But then we have others who have really irrational beliefs and, are prepared to, be persuaded by arguments like, microchips and, harm to the body and, natural is best. But we know, no vaccine is ever licensed if the side effects from the vaccine are anywhere near the side effects from the infection. So, the odds are always in the favour of the vaccination. And if you're going to play Russian roulette with anything, I would rather play Russian roulette with a vaccine than I would with natural infection. So what is the safety and the efficacy of combining different vaccines? Well, their data on that is coming out, and it does look like you are going to get a much more immunogenic response by using a different type of vaccine. There's some concern if you're using adenovectors that you're going to produce antibodies against the adenovector and not against the spike, which is what you want. But all this is being worked out at the moment. So I think that our third dose is likely to be a mixed dose, and I think that's probably the right thing to do. Is it possible to produce a lateral flow test to test for antibodies and to better estimate efficacy of vaccine? Yes, absolutely. And we and others have done this. There are commercial antibody tests out there. And we've also devised one that works for serum and works for saliva. But there are groups that are commercializing this and trying to get this out there. I think being able to understand the role of when you should antibody test is being determined at the moment. So what's the clinical indication, the clinical utility of this test? So for me, the reason most people are going to respond beautifully to the vaccine. And, we don't test people's responses to measles, mumps, rubella or tetanus because we know that most people respond really well. Where you worry is patients who are at risk, so immune deficiency patients or those on immune suppression or have organ disease. So ensuring you get some indication of the fact whether these individuals have antibodies after vaccination, if you test 4 to 6 weeks later, is clinically useful. And this is how I am using the test in these patients. And I will probably then also think about using this test post-boosters and looking at the longevity of that response. I don't think you need to test to see whether someone has had infection, to decide whether to give them a vaccine or not. I think we've got really good evidence that you just need to go ahead and give the vaccine. In some part of the world, you still need antibody testing to look at seroprevalence and look at how many people have had the infection. But as PCR testing has come on board more and more in many countries, actually we have a better idea of what infection rates have been. So I hope that addresses some of your questions directly, and good luck with everything.